All right, we'll get started. A couple announcements. Our next Grand Rounds is on the 16th. Sonny Lindeber is going to talk not about new drug updates. We don't have a topic yet, but it will be pharmacy related. Our next Journal Club is on the 9th via Zoom. And the presenters are Jean Otero Medina and Madison Turner. Other announcements, following today's Grand Rounds, you'll receive an email with a link to the recording of today's presentation. And in the email, there will be an online evaluation. Your feedback's very important to us, and to the speakers, so please take a minute to fill this out. And if you have questions, you can submit them at any time in the chat. So we have two speakers today. Dr. Lauren Hinrichs-Kinney is a physical therapist and implementation scientist and educator dedicated to improving rehabilitation care in older adults. She earned a DPT from Northwestern University, completed an orthopedic residency at Temple, and received her PhD in rehab science at the University of Colorado, along with formerly serving as an advanced geriatrics fellow in the GREC. Lauren Hinrichs-Kinney is currently an assistant professor in the University of Colorado Physical Therapy program, and she's the associate director of education and evaluation within the GREC and the director of implementation science for the Restore Lab. Her work integrates implementation science, workforce development, and education to enhance rehabilitation practice and improve functional outcomes for older adults across the healthcare setting. And we also have Dr. Audrey Keleman. She's an occupational therapist and a rehabilitation researcher focused on optimizing older adult health and ability to age in place. She earned her master's in occupational therapy and in a clinical investigation and a PhD in rehab and participation science from Washington University in St. Louis. She is currently an advanced fellow in the GREC and a postdoctoral researcher here at the University of Colorado. Today, Dr. Hinrichs-Kinney and Dr. Keleman are going to talk about the journey of a complex rehabilitation intervention, efficacy to effectiveness to implementation.
Thanks, Jess. Okay. And I think does it sound, can you hear me okay? Okay, perfect. Okay, so as Josh said, we're excited to be here with you all, and we're going to talk about a complex rehab intervention, kind of from initial efficacy stages all the way to implementation on a wider scale. Okay, and yeah, we just said that. Okay, so over 13 million older adults are hospitalized each year. And while they're hospitalized, older adults experience rapid strength and mobility loss, in large part due to bed rest and immobility during their stay. So not only are they recovering from the reason they came to the hospital in the first place, but they also have this added decline in functioning while there. To address these hospital-associated functional deficits, many patients go to a skilled nursing facility, or commonly called a SNF, for rehab after hospitalization. Unfortunately, while in SNFs, patients continue to be largely sedentary. Studies show SNF patients receive low-intensity rehabilitation and have limited opportunities for physical activity, which translates to poor physical function. And only about 50% of patients discharge home at functional levels that support community living. And if they do make it home, we see as many as 29% return to the hospital within just 30 days. And this readmission is strongly associated with mortality and long-term institutionalization. One reason for these poor outcomes and negative cycle is physical function at SNF discharge. As I said, it's not adequate to support levels needed to support community living. So problems arise such as falls or adverse events, which bring them back to the hospital. But physical function is a modifiable risk factor for poor outcomes. So there's a great need and opportunity to improve physical function, especially while in the SNF setting where they're receiving rehab, to break this cycle. And again, one reason for these poor outcomes may be the way rehab's delivered currently in a SNF. So SNF rehab care has been characterized mostly by low-intensity activity, such as the bikes shown here, that may not challenge muscles and systems enough to make changes in strength that influence physical function. But we know high-intensity resistance training improves strength and function in older adults, even those with medical complexity. but it's less often used in SNFs. And getting these higher intensity doses into rehab practice is very challenging. So to help facilitate use of higher intensities in SNF rehab, Jen Stevens-Lapsley and team designed the Intensive Therapeutic Rehab for Older Skilled Nursing Home Residents, or iStronger. It's a program that can be used by physical and occupational therapists. So to keep it as simple as possible to translate into SNF rehab, it's based on the principle of an 8-rep max, so achieving exercise form failure on about the 9th repetition of an exercise. So this failure is muscle overload, which triggers an increase in strength. And this principle is translated for rehab interventions in iStronger in 3 main categories. So the first is high intensity resistance training. That's the simple 8-rep max. It's also translated into 80% intensity for more gait and neuromotor. They're common practices in rehab. And in this case, a patient should be successful at the task they're doing about 80% of the time, or failing about 20% to ensure that higher intensity and challenge is being reached to elicit change. And then lastly, activities of daily living, or ADL training, they may use either guiding principle, so the 8-rep max or the 80% rule, depending on the task. So sometimes it can look like repeated transfers of an ADL, or some is more the walking and balance part, which would use the 80% rule. So our pilot study for iStronger took place in the VA equivalent of a SNF, and it used a pre-post design. PTs and OTs were trained on iStronger and implemented for a year. And this pilot study found iStronger was safe, so there was no adverse events. Clinicians delivered iStronger with a high fidelity, and patients reported high satisfaction with the intervention. And then other outcomes shown here are increase, which is good, in the short physical performance battery and in gait speed, and those are both measures of physical function. 20% more patients being discharged home to the community, and length of stay decreased by a few days, and there was a cost savings of about $1,000 per patient. So these are all positive outcomes and very promising pilot results. But as this just took place in a single SNF, the large degree of heterogeneity in SNF patients and in other SNF sites requires larger study of implementation to expand it, which we'll go into next.
Thank you. Yeah, so as Audrey mentioned, very promising results, right? But that we needed to then, for the next step, kind of evaluate it across a large population of more heterogeneous SNFs. But we also knew that implementation is complex, and so we really wanted to pause for a moment and take that step to understand implementation, to understand the context in which we were going to implement this very complex intervention. So we took very intentional steps to first develop a theory of action and then develop an implementation strategy that then we could use in that next trial. So to accomplish this, we were very fortunate to receive support for a multi-year quality improvement initiative within the VA. And across these years, this incredible team sought to first develop an implementation strategy, evaluate that strategy, and then optimize that strategy, all the while collecting information on the various influencing contextual factors. So we developed the strategy through consensus methods. We evaluated that strategy in 8 skilled nursing facilities across the VA. And then we took those lessons learned and optimized that strategy a little bit and evaluated that optimized strategy then in 8 additional SNFs within the VA. So as part of this work, we also developed an iStronger implementation research logic model. And so this logic model really helps us organize all the various implementation frameworks that one would use in an implementation project. And it really supports implementation planning and implementation evaluation. And so we're going to use this logic model to both highlight what we learned in this quality improvement initiative, but then also present our results for our effectiveness trial. So unfortunately, just given the nature of timing during the COVID pandemic and just the nature of the project, we were unable to collect patient outcomes for this particular quality improvement initiative, but we did collect clinician level outcomes. So our strategy started with training and educating clinicians on how to deliver iStronger. changing the infrastructure such that we provided the necessary equipment to deliver the program, but then also monitor program safety. We provided interactive assistance. We got online with clinicians and went through case studies and kind of troubleshooted some patient cases that they were having challenges with. And then we supported clinicians by providing twice weekly reminder emails and just kind of tips and tricks in that fashion. So that's what we started with. And then the sites really expanded on this by taking intentional steps to engage the patient in the program, and then also kind of appointing an insight champion to champion this program. So we originally targeted clinician knowledge, clinician confidence in their ability to deliver the program, and then clinician perspectives on the program. But what we learned is that the strategy also influenced continuity of care and kind of team cohesion, salience of the intervention, accountability to deliver the intervention, and then a really, I'll say, supportive patient environment. And that process resulted in moderate clinician adoption, but limited clinician implementation. And these were all based on self-report. So then when we explored what contextual factors really influenced those implementation outcomes, we learned that clinician perspectives was really influential. So both how they perceived the complexity of the program, but then the compatibility of the program with their patient caseload. Organizational leadership was very influential. The extent of patient engagement in the program was very influential. And then just that implementation and sustainability infrastructure. So did they have additional equipment above and beyond what we received that we saw to be very influential? This tension for change or need to do something different than what they were already doing was very influential. And then having these communication channels to kind of communicate what they did with the patient, how they did that with the patient across the patient's plan of care. And so with that, we knew we needed to enhance implementation outcomes through another round of strategy optimization. So we worked really hard to streamline the training and include interdisciplinary knowledge, so providing some insight to nursing as to what rehabilitation was doing so they could also encourage patients. We knew we needed to enhance on-site presence to really mentor clinicians through challenging patient presentations, as well as to help influence their perspectives. We knew we needed to empower formal and informal leadership, so we started to create a leadership and champion curriculum so that they can influence the implementation climate and provide that operational support, that relational support, and championing that the program required. And we really worked to set up the environment to make the intervention even more salient, enhance choice architecture. So we made iStronger the easy thing for them to do versus usual care being the easy thing for them to do, and really took steps to really enhance team communication and continuity of care. So we applied all those lessons learned from that quality improvement initiative to the Hybrid One effectiveness implementation cluster randomized trial, where aim one was to evaluate iStronger effectiveness on patient functional performance outcomes, and we used the change in gait speed for this specifically. And then aim two was to really use that re-aim framework to assess implementation and then characterize the implementation process and identify influencing contextual factors. And we were very fortunate enough to partner with Aegis Therapies, who contracts rehabilitation to various skilled nursing facilities across the country. So randomization occurred at the site level. So sites were either randomized to deliver usual care or to be trained in how to deliver iStronger. So during that, what looks to be very long pre-experimental phase, sites that were randomized to iStronger received clinician training in how to deliver iStronger, as well as other implementation strategies we'll talk about here in a second. And then during that experimental phase, clinicians were coached to continue to deliver iStronger to the patients, and then clinicians at usual care were just encouraged to deliver care as usual. And then both study arms collected our primary effectiveness outcome, and then we worked really hard to collect our implementation outcomes during that experimental phase. So again, we kind of grounded ourselves in this implementation logic model to plan for evaluation, but I first want to zoom into what we actually did, what our implementation process was for this very large project. So we aimed to target the same mechanisms. We aimed to influence clinician knowledge, self-efficacy, perspectives, continuity of care, salience, patient environment, accountability. And we did that by, again, we continued to train and educate clinicians, but we also really supported our clinicians through more on-site mentorship. So we were actually at each site for an average of like 4 to 5 visits throughout their 15-month experimental phase. We appointed and educated a champion in how to be a champion, and kind of coached them through that process. We took a really rigorous approach to readiness assessment and needs assessment for each site to kind of understand the unique needs of that site. We put together communities of practice with an internal implementation facilitator, so that's somebody who was hired by Aegis within the system, so they kind of had their ears to the ground, their eyes on everything that was going on within Aegis. So they kind of hosted that community of practice with us. And then we hosted monthly calls as an external facilitator with each site monthly. And then we used evaluative and iterative strategies. We ran audit and feedback cycles and developed dashboards for clinicians to kind of see how their implementation outcomes were evolving throughout the project. And then again, we continue to provide equipment that they would need to deliver the project and change their EMR so that they had that enhanced communication and documentation ability. And so that we hoped would positively influence our implementation outcomes, so how well that site delivered the program. We hope that that also too influenced our dose or our reach outcomes, so what the patients received, and then that would then positively influence gait speed. So that's kind of our theory of action there. So for our primary effectiveness outcome, physical therapists at each site collected gait speed at evaluation and discharge, and then that was entered into the EMR. And then also throughout that experimental phase, the research team, as well as the appointed champion, monitored reliability in which they were collecting gait speed for us. And then also during the experimental phase, we collected implementation outcomes. So reach was really that dose received by the patient, and that was operationalized by the proportion of their rehab sessions that were iStronger. So if they had 10 rehabilitation sessions total, we looked at how many of those were actually iStronger and kind of got that proportion for our reach outcome. And then for implementation, we operationalized that as the fidelity to really the intensity of that intervention. So dose was kind of that consistency piece, and then implementation was really that fidelity or that accuracy piece. And then also during the experimental phase, we collected a lot of qualitative data to understand what was influencing the site or what was influencing the clinician's ability to both deliver that dose with fidelity. So I'll let Audrey step in for the analysis part.
Okay, our primary analysis was intention to treat. So this means patients are analyzed according to the group they're assigned. So whether they were at a usual care or an iStronger site, regardless of whether they received the intervention or not. So this preserves benefits of randomization and minimizes bias. And the primary analysis, as Lauren said, is change in gait speed from admission to discharge. And then we looked at that from iStronger sites versus usual care sites. And we used general estimating equations, accounted for clustering within sites, and controlled for age, sex, baseline gait speed, and rehab length of stay. But we also wanted to understand in iStronger sites a little bit more so we had some secondary analyses planned. So dose response, we wanted to look closer at the dose patients actually received and its influence on effectiveness. And then also effectiveness by how successfully sites actually implemented iStronger, and then qualitatively identified factors that influence both dose and implementation success. We randomized 32 SNFs, and then 16 were usual care and 16 were iStronger. And there was one dropout from each arm, and we ended up with data from 15 usual care SNFs and 15 iStronger SNFs. On a patient level, at each iStronger facility, clinicians were trained that patients can receive iStronger if they had no contraindications to high-intensity resistance training, no lower extremity weight-bearing precautions, and no neurological disease. And then we included data on all patients who were over 50 years old, admitted to SNF from the hospital, and ambulatory upon admission. So with this criteria applied, it led to about 2,000 patients per arm. Okay. And this table summarizes some participant characteristics from each group. There were no differences between groups. The average age was about 79 years old and about 65% female. We were missing quite a bit of BIMS data, which is the brief interview for mental status that we got from the MDS, but the average was about 12 out of 15. 15 is the highest you can get. So indicating largely intact cognition, or below 12 would be possible mild cognitive impairment. And the average rehab length of stay was about 18 days. And importantly, the rate and type of adverse events did not differ between groups. This indicates that, contrary to some initial hesitation, delivering high intensity to this population is safe. And this is looking at our primary outcome, change in gait speed from admission to discharge. Both usual care and iStronger groups improved to a clinically meaningful extent. We did not, however, see superior improvements in the iStronger group. And again, this was intention to treat analysis where all eligible patients from an iStronger site were included, regardless of the extent to which they may have gotten iStronger. So for that reason, we wanted to look closer at the dose that was actually delivered to patients. And then placing into context, so I don't know if I could. So this was our aim. One, results did not differ, but then we wanted to look a little closer at the dose actually received. So just placing it into this logic model that we've been looking at. Okay, this is dose patients received. We looked at it as a distribution, this distribution as a proportion of total number of rehab sessions that were delivered as iStronger. So we see there's a large group that didn't receive any iStronger sessions. There's a few that received all of their sessions as iStronger, and then everything in between. So with that distribution, we wanted to understand the relationship between dose and the outcome, change in gait speed, and understand how much dose was needed to see a clinically important difference beyond what we saw in usual care. And this figure represents that relationship. So here the x-axis is the dosage of iStronger, again represented by that proportion of their total rehab sessions. And the y-axis is the predicted change in gait speed from baseline to discharge. So higher is better. And this regression line represents that for every 10% increase in iStronger sessions, there was a 0.007 improvement in gait speed. So we know that all people made improvement, and that represented by this line. But a clinically meaningful improvement beyond that level is seen by this top dotted line. So the MCID would be that line or above. So what this means is to see a clinically meaningful improvement beyond what we observed in usual care, the dose of iStronger needs to be 70% of sessions. Or if a patient had 10 sessions, having 7 of those sessions be delivered as iStronger would meaningfully improve their outcome. And then returning to our dose distribution, we see that very few patients received 70% or more of their sessions as iStronger. So this was actually only 11%. So again, this may explain why overall there was no difference between usual care and iStronger in our primary outcome.
Okay, so we saw a relationship between dose and effectiveness, but so far we've only represented the frequency in which a patient received iStronger. We also care about fidelity, so the quality and the accuracy in which they received that intensity or that level of intensity. So to represent both frequency and fidelity, we ranked sites according to implementation success. And so to capture that, we triangulated our ethnographic data. So again, we were on site several times and took good notes of what we were observing. So we had that ethnographic data. Over 100 interviews and focus groups were collected, so we had all of that data. And then we also had our quantitative frequency and fidelity data. So we triangulated all of that data, and the team met several times and reached consensus by classifying sites as high implementing sites, moderate implementing sites, and then low implementing sites. And so we did see an influence of the extent to which sites implemented on patient outcomes. So patients that received care at low implementing sites actually did significantly worse than usual care. However, patients that received care at high implementing sites did significantly better and in a clinically meaningful way. And so we really wanted to, again, understand what influenced this range in dose, what influenced this range or widespread in implementation. So we're still kind of sifting through all of our qualitative data. So these are pretty preliminary themes. But what we're hearing from clinicians, what we're hearing from champions and leaders is that clinician-identified patient factors, clinician factors, and then organizational factors really influence their ability to deliver iStronger or the patient's ability to receive an adequate dose of iStronger. So, and then all of these obviously kind of influence each other. So if we narrow into patient factors, and again, these are clinician identified patient factors, pain got in the way, obviously, of delivering the program. The level of a patient's cognition influenced the clinician's ability to deliver or their perceived ability to deliver. Lower level of baseline function, we heard from clinicians, made it a little bit harder for them to kind of think outside the box to apply this high intensity program. Again, the patient's level of engagement. Exercise requires engagement from the individual. So the patients obviously on the lower end of feeling engaged, it was harder to kind of motivate them to engage with that project or with the program. A patient's insurance, we heard from clinicians, actually influenced their ability to deliver the intervention with fidelity. And then what we're hearing from clinicians is just there's a shift or in an evolution in the case mix, essentially, such that there's higher complexity patients with competing medical and or personal needs, which influence their ability to deliver. When we kind of looked at that clinician bucket, we're understanding really that fit with their preferred practice patterns and their philosophy on how rehab should be delivered to older adults. That was very influential. Their outcome expectation, and so if they thought iStronger was going to work, obviously they were more inclined to deliver it versus if they didn't believe that it was going to work. And then training exposure. So we worked really hard to train everybody in the facility, but there was frequent staffing changes and staffing turnover such that obviously training exposure would influence their ability to deliver the program. And then when we narrow into organizational capacity, productivity, group and concurrent expectations from Aegis essentially influenced their ability to deliver documentation and communication. This is a progressive, not only is it high intensity, but it also needs to be progressed across a patient's plan of care. So if Audrey saw a patient on Monday and I saw a patient on Tuesday, I would need to know what Audrey did with that patient. And if there wasn't a rapid way for me to collect that information, it would be really hard for me to progress the program and deliver the program. Again, staffing stability was challenging, but not only staffing stability on the clinician side, but staffing stability with nursing also influenced clinicians' ability to deliver the program, adequate space and equipment, training penetration, which is kind of redundant to the training exposure, but what we learned is that we trained around 100 clinicians in how to deliver iStronger. And then when we looked at our patient data set and looked at how many different clinicians actually provided care to the clinicians, it was 400. So we trained 100 and 400 delivered care to that patient. So training penetration definitely influenced the ability to deliver the program. Leadership and championing and just having a rehab forward facility culture was very influential. And then aside for these influencing factors, we learned a lot from clinicians on how their behavior and their approach to care really changed. And then how the patients really took to and benefited from this program. So just a couple quotes. I had no idea how much I was underdosing my patients. They not only tolerated high intensity training well, but now I was tailoring the intervention to that person's capabilities versus kind of just standardizing care. And it's been a good way to motivate our patients to do more and even improve our own expectations of what they can do to move forward towards things that's going to make their life easier once they discharge. And I think we might have time for the full video. So we do have a little patient testimony here, Leo, and we tested this and it worked, but the visual kind of got a little, yeah.
It's at another level. And I'm so motivated. I'm so excited every time I go to therapy that You know, I just can't get enough of it. I come into my room and I'm doing this at night, guys. Look, right here on my own, in my own room. This is how motivated I am.
And how was the intensity compared to where you were before in terms of therapy experiences? Was there a difference in the types of things you were doing or the intensity with the weights and things like that?
It was a major difference. Just the intensity and the different things that I'm doing versus before over there was just real simple. This started out simple and it started getting harder, but I could see how it was working, what it was doing for me, and the final results, you know, and my intensity is just, I'm highly motivated all the time.
Did you ever get to wear the weight vest?
I sure as hell did. Thank you to Mr. Ronnie. I looked at it and I kept saying, okay, so, you know, we put the weight vest on, you know, and I do this bit right here, and I do it 5 or 6 times. Okay, hold on. And all I know, before you know it, he's adding more weights to it. And then I told him, I said, Ronnie, how much am I putting on? Or what do you have on me? Oh, just 40 pounds. But hey, guys, you know what? Thank you, Ronnie, wherever you're at. But yes, it was another level, and I could see why.
So again, he had that opportunity to receive usual care from a prior stay at a skilled nursing facility and was able to compare that to the iStronger program. So just encouraging to hear. So though a very rigorous mixed methods pragmatic trial, there were limitations. And so gait speed was collected from the clinicians in the clinic. And though we did our best to really monitor reliability, we did see some drift with how they were collecting gait speed. And so we had to intervene on that quite frequently. Dosage data was fairly subjective. And so to get that dose after every treatment encounter note, the therapist would click a box that said, yes, I delivered iStronger, or no, I didn't deliver iStronger. So that was pretty subjective. And then our fidelity data, we did the best to assess fidelity when we were on site, but obviously we couldn't be there all the time. So we were doing remote fidelity. Our champions on site were capturing that fidelity at different rates. And so obviously some of our data sources had some limitations there. But to wrap everything up, I wanted to go back to our logic model here. So iStronger's influence on physical function was really at the same rate as usual care, right? But that was according to our intention to treat analysis, as Audrey described earlier. So all patients that were in our data set that received care at an iStronger site, regardless of getting iStronger or not, were in that intention to treat analysis. We also know that there's a relationship between the dose that the patient received and their outcomes, and then how well the site delivered the program and their outcomes. And we also know it's safe, which I think is really encouraging. But we intervened here. And so with intervening here at that red box means that we were really reliant on system changes to occur, clinician behavior changes to occur, for the patient to receive an adequate dose of the program, for then us to see effectiveness outcomes or change in gait speed. And so with that, our next steps include really understanding and balancing like a feasible but the most optimal approach to optimizing implementation. So being on site 4 times for 15 sites took a lot of resources. So we're still trying to understand how we can really support clinicians and how to deliver this intervention with fidelity and what that would take. But at the same time, we need to understand maybe what patient groups are most likely to benefit. So Audrey walked us through some of our inclusion and exclusion criteria, but it's still a pretty heterogeneous group in our data set. And so we're working right now to really understand for what patients does this work for, and maybe what patients need a different kind of dose of iStronger. So that's currently what we're working on now. And so with that, obviously thank everybody in this image and all the names that we can't mention right now, and just gratitude to you all for listening and asking questions and hopefully giving good feedback. And we'll take any questions. If you have any specific questions on iStronger, you can find that at this QR code here. But obviously we're happy to walk through that and take any questions.
Thank you, Lauren and Audrey. Fantastic presentation. I love the story of taking a pilot to implementation, and it was a very thoughtful approach. I have a lot of questions. I'll start with a really simple one. One of your exclusionary criteria was neurological diseases. What was the thought process on excluding individuals at SNFs with neurological diseases?
Yeah, that's a great question. So I will say that we do still have those patients in our data set, which is nice. So we were trying to kind of narrow how heterogeneous a population could be and make it a little more homogeneous. I don't want to make it too confusing, but when we train clinicians, we train them to really provide it to anybody, aside for the obvious like contraindications to high intensity resistance training. So we do have a plan of looking at that patient population's response to this program, but that just wasn't in our primary outcome. Yeah.
Questions from others?
I have a bunch of questions because this is such a wonderfully comprehensive implementation study. It was so nice. I guess my biggest one is, after everything you've seen, would you recommend any changes to the intervention? Like, have you considered making any changes to iStronger?
That's a great question, because just the evolution of iStronger, we didn't really reference this, is when we first packaged it, it was a little bit more prescriptive in that we told clinicians that 30% of their session needed to be on therapeutic exercise, 30% needed to be. So that was kind of taking autonomy away from the clinicians. And we felt like it would be more easily adopted if we just told them, take what you're already doing. You do not have to change what you're already doing, just up the challenge or up the intensity. And so that I don't think I would change, because I do think that's easier. This is just the world as I see it right now. I do think we need to add a little bit of behavioral coaching into it. Again, patients' level of engagement and readiness to kind of partake in this was very influential. And so adding that, I think, would be great. But I don't know how much more we could really change, because we've kind of diluted it to like, do what you're already doing, but just make sure that the patient is working at like an RPE, or a rate of perceived exertion, of like a 7 to an 8 out of 10. So yeah. Oh yeah.
My question's kind of a follow-up on that, and thank you for this work. I think it's very, very important. But do you think that you could, do you think that part of the results are because of just using the same setting, the same equipment? Do you think you could produce better results were you to have, say, an infinite budget to be able to like have better gym equipment or have more gym equipment?
Yeah, let me know if I'm answering your question. So there were some sites that already had like Nautilus equipment and various space, honestly, to do this, and those sites did tend to do a little bit better. So if they had baseline resources that were more aligned with this approach, it was a lot easier for them to deliver. And not only because they had like the physical, but they also had like the conceptual, like, oh, I've already done a little bit more challenging rehab to these individuals and they were fine. And it aligns with my practice patterns. So it was both the physical, but then the cognitive alignment with that. Yeah.
Hey,
Hi.
Thanks so much for presenting to us. As you know, I love the trial and the iStronger intervention. Seeing the implementation side, whenever I think about pragmatic trials as opposed to efficacy trials, the efficacy trial, the intervention is the intervention, right? The higher level intensity of rehab. But in a pragmatic trial, it is the recommendation and the training is actually the intervention at day's end. And the complexity lies in how you go from that training all the way through to whether or not people get it. I was just curious to know, in the training that you did with staff, was there also training about how to introduce iStronger to patients? And was that something that you controlled, or was that not part of the intervention? It was just like, no, try to up the intensity, but there wasn't like suggested language around how to introduce it to a patient, like, we're going to kick your butt a little bit or something like that.
Yeah.
Just curious to know how that, what went into that planning.
Sure.
Well, you developed
Okay,
all the
okay. I just
yeah,
didn't.
like
Okay.
this.
So the first iteration of training, no. And then we took the lessons learned in that second iteration of training. We did give a module on motivational interviewing. And so again, then it's hard to disentangle like what's iStronger and what's MI, because MI obviously has an influence on patient outcomes. But yeah, so they were coached in how to do that. It wasn't part of our fidelity checklist, in that like it wasn't required to say that they were delivering the program with fidelity, but we did give them strategies on how to do that. And it's interesting because some clinicians said that they told them that they were going to be doing something more challenging, and some clinicians would rather not say anything, because a lot of patients, rehab is rehab, and they don't They don't know the difference aside for Leo, who we talked to. So they were fearful that telling them that would actually like limit their willingness to go down to the gym. So we left it up to the clinicians and how they related to their patients. But
Okay,
yeah.
I do have something. Also to say, Lauren has been on this from the beginning, and a big part of this that she shared is her dissertation, but I just joined a year and a half ago. But one thing I can say to speak to that, though, is coming from, I'm an occupational therapist, and a lot of this is physical therapy, but that when I did some site visits, especially for sites that were OT was lesser implementing or reporting more problems with it, that was a big thing I coached them on that seemed to help, of especially with activities of daily living. If you, since that is something that they will actually be doing, it's not an isolated exercise that they won't, and besides Leo, do in their daily life. I think it's important to make sure they have the cognitive capacity to understand, like, don't do it this way if it's an ADL all the time, you know, when they're unsupervised or in their room alone. So understanding that you do have to introduce it a little more and make sure, compared to just like isolated gym exercises, you know, not in their room or in the bathroom.
I had a couple questions about the barriers that you identified. There was a lot of them. And pain was one. And I'm curious if that was inherent pain that the patient has, or if that was pain in response to the high intensity exercise. That's my first question.
Yeah, that's a great question. It was actually pain that they had at baseline going into the program. So if they had degenerative rotator cuff pathology, how could we prescribe a high intensity exercise to the upper extremity working around pain? And part of the module, so we did learn that that was a barrier in our pilot. And so we did put a module together on like how to work around joint pain and how to distinguish joint pain versus muscle pain or delayed onset muscle soreness. So that was part of the training. Yeah. But basically it was the pain that came at baseline was very influential. Yeah.
Great. That's helpful. Second question. Insurance coverage was a barrier, but what you're implementing is physical therapy.
Yes.
How was insurance coverage a barrier then?
That's a great question. So when we look at, so dose is complex, right? Because they have dose is intensity. So are they reaching failure with an exercise in a session across the plan of care? So there's a lot of levels there. So when we looked at really the rate at which they received iStronger, insurance dictated how long they were in the facility. And so that was really influential. So I think lengths of stay like ranged from 1 to like hundreds. And so that's really, it's how frequently they were able to see the patient. And we saw honestly within a site, within a patient, insurance carriers changed because iSNP was adopted across some of these states essentially. And so a patient would be on one insurance one day and then a different insurance the next day. And that cognitive load on the clinician was just like, I'm just going to go back to what's comfortable because I can't keep that all that in my head. So yeah, that's kind of the two ways that we saw it.
Great. Third question related to that. Again, there was a lot of them there. So what were the most common barriers and how are you thinking about addressing these barriers, perhaps in modifying iStronger in the future to reduce this barrier load?
Yeah. So do you have any, just with being on site visits?
No, I feel like your qualitative
Okay.
data would be better.
Really, again, and this is our qualitative data is from the clinicians. We weren't able to capture any qualitative data from the patient. So this is just clinicians' perspectives of the patient experience. A vast majority of the challenges were at the level of the patient. And that's why I think it's going to be really fun and really important to kind of substantiate what we're hearing as a perceived barrier on the patient level to what we're actually seeing in our quantitative data on what patient factors really influenced effectiveness. So it was really that patient level that we're seeing. Yeah.
We have one person online, Connie Cole, if she wants to come off of mute.
Thank you. And thank you for this important work. Getting people stronger to go home is a fantastic goal. But given the variability in nursing facilities across the VA and CNHs, can you talk a little bit about the types of facilities that you implemented in and whether they were CNHs? Yeah, I know you mentioned VA SNFs. And if not in a CNH, how you would move this into a CNH that's not associated with the VA? And maybe how that would affect case mix and like subsequent Medicare payment. And maybe if the type of facility even affected the results?
Yeah. Hopefully I'm answering your question. So CNH, can you? Oh, yes, correct. Okay, that's what I thought. So the pilot project that we did was in the VA. And then the hybrid one effectiveness implementation trial was all in the private sector, essentially. So we just contracted with Aegis, and Aegis is a contract, they contract rehab in various various skilled nursing facilities. So that approach. But I would say just the variation in the facility itself, we saw some degree of variation in that some had a lot of long-term beds versus short-term beds. Some had, I think, kind of like more thank you, memory care units. So that obviously influenced the patient case mix. But to be honest with you, we are looking at, because we stratified tables into implementation success. And so we're now looking across these site level characteristics to see if like that maybe just explained their ability to deliver implementation. And the only thing that I'm really seeing, and this is preliminary, the only thing that I'm really seeing right now was the size of the facility. So the smaller the facility, the smaller the team, the higher likelihood they had of being successful with implementation. So everything else was pretty evenly spread with the memory care units versus rural versus urban versus that demographic. So does that answer your question?
It does.
Okay.
Can you follow up a little bit? Does that affect any of their Medicare payments for those patients or not?
So we did look at payer across sites, and that didn't differ. I'm looking at somebody else that has their eyes and ears in the data as well, but that didn't differ across sites.
Good to know.
So yeah. Thank you for the question.
Thank you.
Mm-hmm.
Thank you for your presentation. So I, along with Dr. Bolin, work in rehab. And have worked in the private sector and worked with VA nursing homes. And thinking through your data, I agree, payer source is a huge source of frustration and I'll say like maybe economic pressures from patients themselves.
Yes.
For discharge and things like that. If I was a medical director at a facility and you said, hey, we have an intervention that improves gait speed, convince me that that's helpful as a rehab doctor.
Do you want that, or do you want me to?
I feel like that's a PT.
Okay.
Gates.
We do. Do we still have that? Do we still have the gate speed slide? Well, let's do this. So this was actually suggested by a colleague of mine, and so this chart essentially represents how gait speed kind of is operationalized in physical function, right? So 0 to 1.4 and kind of what represents maybe an ability to walk in the house versus an ability to walk in the community versus the ability to be a community ambulator. And so the far left dashed line, this isn't pretty because I put it together last night. So right just before the 0.2, that was what they were at baseline on average. So on average, on admission, patients walked at like about, I think it was 1.9 meters per second. So that's 0.1, yes, sorry, 0.19. So dependent for hospital, ambulation, maybe household walker, there's some limitations there. So then that next red dotted line around that 0.4 is if they received 0 eye stronger, that's how much they improved. So they're still just restricted to the home. If they were to receive eye stronger, that's that final dash. So that's that clinically meaningful improvement. If they received 70% of their sessions as eye stronger, now we're giving them the opportunity to engage in the community.
The only thing first, this paper, the first authors here, Addie Middleton.
Addie, you want to
but also more functionally from like an OT perspective, I would say gait speed is it's very well established that it's associated with other functional measures. So I would kind of lean on that too to explain the value to someone else.
Yeah, thank you. And thinking of your pilot study, a follow-up with all the improvements, and if I'm thinking about economic pressures, Medicare Advantage payers, the length of stay would be my focus.
Yeah.
And thinking of that in this, I still would want more, I guess, practical data, like
Sure.
functional ADL improvement, and things like that. Has that been discussed as a team?
You can talk about the MBI.
Yeah,
Yeah.
we do have the MBI as an outcome. It's similar results. It improves in everyone. I would have loved as an OT, a performance-based ADL measure, because there's a lot of limitations to the MBI of like facilities have to capture it. And that's also one way that people are looking at nursing facilities as a whole to see if there's improvement. But we did see similar trends in that too. Yeah.
And we do have access to GG codes, correct? So we can look at GG codes. The hard thing with those codes, they're not very sensitive. So to jump from one score to another takes a substantial amount of change, whereas gait speed is quite a bit more sensitive and predicts a lot of other functional outcomes, including morbidity and mortality. So, yeah. What does that stand for? So it's just the section of the MDS that represents physical function. And it's standardized collection across all skilled nursing facilities. I don't know exactly what measures are in there. Probably should be more familiar with that, but it represents physical function and functional ability. Yeah.
When you were talking about the dosage response, so people who had higher dosages of the intervention had better outcomes, I think that could mean two things. One, that if people are given the intervention more, they do better, or it could mean that clinicians are better at identifying patients who will improve more. And so there's like the confounder of clinician choice or like selection bias. How did you think about that in terms of, is it the intervention being given versus the patient selection? And does that has that played into how you think about which patients maybe benefit most and who you do the intervention on?
Yeah. And that figure that I showed, like dose kind of an arrow to effectiveness, it's a bidirectional arrow, because certainly as a clinician sees a patient improving, then they're going to be more inclined to deliver that dose. There is definitely a lot of selection bias. So again, we told clinicians to apply it to everyone, aside for contraindications as defined by ACSM to high intensity resistance training. And that's more at the cardiovascular level and the health condition level of being acute after a cardiovascular incident. But again, what we learned is that though they didn't meet the contraindications, that clinician just had a harder time or they weren't able to deliver it. So there was a lot of clinician selection bias, and we're trying to disentangle that now when we kind of look at, we're both going to look at responders. We're going to do a responder, non-responder analysis, essentially looking at patient characteristics, but we also need to control for that dose that they received in that as well. So we're working on that. But yeah, that's definitely something that we're taking into consideration.
Great. Well, thank you so much. Obviously, lots of interest in the topic, and I'm glad you left time for questions. I have 2 comments and 2 questions. So the first one is, can you go back to the videos at the beginning? Because I don't know, Audrey, if we really focused on what was happening there, and I want to be sure that everybody walks away with that image in their minds. So,
Something that we didn't show, we have another video where we zoom in on the screen and the bike is actually registering 0 output.
Sorry,
which we didn't
have done this in a better way.
Yeah. So these videos, those are not slow. Those are not slowed down. That is 1.0 speed. And 2 people are sleeping. So just to say, this is usual care, right, in rehab. So just thought that would be important to emphasize. So anyway, that's one comment. And then the other comment is this is one of the first, if not the first, study to show the effect of rehab in a SNF. Right. So this is a really big deal. We have never known the answer to this question, which is fantastic that we now know, and hopefully how to improve it. So just 2 quick questions. One is, nursing home research is really, really hard, and relationships matter. And so the Aegis folks, it sounds like we're great partners. Was there any conflict between the facility and the rehab group as you tried to enroll facilities?
Facility like that were
the nursing home. Did the nursing home say, "Oh yeah, come right in. If Aegis says it's good, we're good"?
I don't recall that happening. I know the sites that did drop out were more so that they lost the Aegis contract. And then there was just some chaos regarding staffing, like they didn't have a DOR and they had an interim DOR and just never found stable leadership there. But I don't think there was any pushback ever from the facility. I will say that we just didn't cast a broad net to all Aegis contracted facilities. We were very intentional with our selection, again, with this being a hybrid one, where our primary aim was that effectiveness aim. And so we did have some facility characteristics that we were looking for. So that could explain maybe more alignment than the disalignment.
Great, thank
Yeah.
you. And then
Mhm.
one thing is, in primary care, if you're speaking to a primary care group, they're always super interested in measuring gait speed, but find the mechanics of it cumbersome. Do you have any suggestions for how to make it just part of the care that happens, short of having what we have, where it's, we've got a little, laser that measures it, but short of that, is there an easy way to go about doing this?
Do you have anything on that?
Yeah, well, just a single spot that it's marked. That was one of the problems that in another hybrid study we're doing, like sometimes because 3 meters, there's not usually a meter stick or there might be a yardstick or there, yes. And then we had, so also translating it into like, I think it's 10 feet, 8 inches or something where they might have a readily available tool to measure that out if there's not a preset course. And then there's problems with some people can't put tape on the ground. So I think for that one, if you have it near a railing, putting tape on the inside of the railing so the therapist can see it, but it's still allowed within the facility. So there's little tips like that, but
Yeah.
still hard.
Yeah, there's definitely other people in our group working on just implementing gait speed, period. And I know they're working with various lasers and technology, but the practicality of providing that to all of our sites was quite limited. And so we were just kind of meeting them where they were at, and we just had to like be there and problem solve with how they can make it more systematic. As Audrey was saying, is like maybe there's just one site or one place in the facility that was designated as the gait speed place. And so nothing had to be like moved or remeasured or whatever. So I saw if Franny do you have a thought?
No,
Because you were boots on the ground too.
Yeah, no, I just had a follow up to your question about, talking to a director and length of stay. We did have a site that had an improvement, like such a change in length of stay that they got more short-term beds. So the facility was like appreciative that we were in there and that, there was this change. And so even because we were there for so long, that 15-month time period, we were able to have some of that impact of affecting the bed size or how that facility was operating. So
Yeah.
I just wanted to make a statement on that.
Thank you for that. That's
Yeah.
helpful. Does that,
Yeah.
yeah. Does that answer your question about gait speed? Okay.
Any last questions?
I love the video of Leo because you can tell how pumped he is.
So yeah,
Like
he
he's
was an
so-
ambassador for the site.
He's just like so into it and so motivated. And that's one of the things I think as a behavioral health provider, we're always trying to encourage with our patients, because we know that exercise has that inherent positive reinforcement and there's mental health benefits as well as, physical health. I'm just wondering if there was if you collected any data or have any interest in looking also at the changes in motivation. Like I'm just
Yeah.
looking at this video that's in real time, so slow, versus Leo, who's like, I want more weight.
Yeah, jazzed about it.
Yeah, he's so jazzed. And I'm just wondering if that was something that you all looked at as maybe a secondary outcome or,
It's-
implication of the
Yeah,
match.
it's not. I really wanted it to be, because on our logic model, there's that intervention mechanisms, and I took it off because it was a little busy. But iStronger, I think, works through strength, neuromuscular adaptation, muscle hypertrophy, and our affective changes. And so we just didn't capture those affective changes, engagement, motivation. We tried to look for like a patient engagement and motivation scale to see if we could add that. But at that point, we were just kind of adding more layers on the clinician. So we just wanted to be sensitive to clinician burden. But yeah, I question, is gait speed, if somebody was there for 5 days, right, and they got baseline gait speed at day 1 and discharge gait speed at day 5, maybe we didn't see a huge change. But if we influence their willingness to engage in exercise, maybe their trajectory upon discharge was completely impacted in a positive way. So more to come, I'd say, but that's a great question. Yeah.
Thank you very much for this amazing presentation. If you stay after for a couple minutes, if anybody else has any other questions.
Thank you. Sorry, I didn't want to.
This is not on. We'll go ahead and take just 2 minutes. We have a speaker here for the start of our division